Like we were just playing on our patio and
Hi, everyone. Testing.
Right.
Testing.
There we go. There we go.
Hi, everyone. We're going to get started. My name is Dr. Kiran Masood. I'm a general pediatrician here and one of the faculty in the Global Health Program. And it's my distinct pleasure to introduce today's speaker, our colleague and friend, Dr. Martine CASAPIA, who is an expert in infectious diseases and global health. Dr. Casapia is based at the Hospital Regional de Loreto in Iquitos, Peru. He has dedicated his career to advancing public health efforts in some of the most challenging environments in the Amazon region. Dr. Casapia obtained his medical degree in specialty training in infectious diseases in Lima, and he's had additional specialized training in tropical medicine and clinical research. He holds a master's of public health from the University of Washington, where he developed a deep understanding of public health epidemiology and global health challenges. Currently, he serves as the leader of the Asociación Civil Selva Amazonica, where he's held and led numerous clinical trials and research initiatives targeting a broad spectrum of infectious diseases, including HIV/AIDS, malaria, helminthiasis, Most recently, he's been at the forefront of the global response to the COVID-19 pandemic in Iquitos, leading vaccine trials that have had substantial impact on public health in both regional and global contexts. A notable aspect of his work is on translating research into tangible health outcomes, particularly for the underserved and remote populations of the Amazon. His research activities have not only advanced scientific understanding, but improved healthcare access and delivery in these resource limited settings. His leadership in these areas has significantly improved disease management and prevention for these vulnerable communities. Today, he will address the pressing issue of dengue fever, a disease of growing concern in tropical and subtropical regions, especially in the context of climate change. His presentation will focus on the challenges of dengue management, drawing from his extensive experience in the Amazon and around other regions of Peru, and will explore strategies for effective prevention, treatment, and disease control. Please join me in welcoming Dr. Martin CASAPIA.
Thank you. Please, thank for the invitation. I'm very happy to be here after to be working for a long time in agreement with the global health because we receive a student for many years in our hospital. And today I would like to talk about the one of the most important problems in the region, not only in Peru or Brazil, that include Central America, South America, including some cases in USA. Yeah. Okay. Okay, I don't have any conflict. WHO have ambitious goals. They expect to build capacity in countries to detect, prevent, and respond to dengue outbreak. The last year, we have maybe the biggest outbreak in the South America. To reduce preventable dengue death to zero, this is very, very difficult, and we will talk about that in the next minute. And reduce the burden of disease and its incidence by 25%. We are so far to reach this percentage, and compared 2010, 2020 as the baseline, with this year, we are so far to reach this objective. Burden of the dengue is the last few years, 50 years, the incidence have increased several times, 20-fold, but one estimate. A year, we have estimation about 390 million infections worldwide. And we have information about estimate 3.9 billion people in 129 countries are in risk of infection. And these countries, not just the same area, in each country increase the numbers, the areas that are infected with Aedes aegypti, who is the vector of this disease. In this picture, we can see how is the percentage of increase in different countries about the number of cases or incidence of dengue fever. With orange, we can see increase until 400% in different countries in the South America, Central America. In this picture, we can see the countries who report cases of dengue. And we can see here in the South America, many countries have very high incidence of dengue fever cases, including Peru, Colombia, Brazil, Bolivia, Argentina. It's important to take into account how the environmental factor have effect over the number of cases. Here, we can see the expectation to increase the areas to be adequate for the vector and dengue transmission. To 2020 to 2050, in red, you can see the increase, the areas, in especially South America and Mexico. Even major efforts that the countries made is expected to increase the areas where the dengue fever will spread. For example, it's expected to total, say, 6.1 billion people will be in risk for dengue fever by 2080. What about the dengue fever in the America? This is an important graphic when we can see over the years how many cases is going up starting in 1980, and the trend is to increase the number of cases, and the last 7 or 8 years, 16.5 million of cases increased, taking the total cases of the country in the Americas. In this picture, we can see the number of cases according to the years compared 2022 with 2023, and it's very clear how increase the number, non-stop to number of cases, even different measure to dengue control, increase the number of cases. When we can explore the number of cases in the Americas, Brazil have more than 2 million of cases a year. This is for 2023. Peru was after of Brazil in number of cases the last year. This is a big problem in terms of public health, in terms of the burden of disease. Other countries are Bolivia, Argentina, also being affected with this epidemic. When we talk about the deaths, the same behavior of this epidemic increase the number of cases. Brazil is the head. Peru had many deaths last year. We faced the most important outbreak the last year, 2023. Here we can compare the number of cases in 2023 and 2024 until the last month. We can see here in Peru more than 273 cases and 441 deaths, but 2023. In this year, with only 8 months in this estimation, we have 262, 840 cases. Brazil is the biggest country who reports dengue cases. In 2023, more than 3 million of cases. But in this year, you can see here, It's 3 times the last year. It means the problem is still increasing in Brazil. Here in this table, we can see different serotypes which are circulate at the same time. For example, by 2022, in Peru, we have 2 serotypes. Then dengue virus 1, dengue virus 2. In some countries, it different of the 4 serotypes can circulate at the same time. For example, Mexico, dengue virus 1, 2, 3, 4, different serotype can circulate at the same time. The previous information is the dengue virus 2 have more virulent behavior, or the people who infected with this serotype could have more severe case. For example, we have other countries in Latin America, in Colombia, the same trend over the time increased the number of cases. 1980 increased 2000, 2010, 2020. The number of cases increased and still keep increasing. In Peru, a little more worse because we face the most important outbreak in 2023. The first register of outbreak was in 1990. Only a few number of cases compared with the other outbreak. This 2001 was the first outbreak registered in Peru. More than 23,000 cases. After that, in 2016, 2017, we have more than 76,000 cases. But in 2023, we have the biggest epidemic, the major epidemic in Peru. It was terrible to see many regions in the coast, some of the jungle, with the building of the hospital that was full with patients with dengue, and many patients dead in that outbreak in Peru. Here we can compare, for example, the number of deaths over the years. You can see here, for example, 2019, 37 deaths, 2021, 43 deaths, but in 2023, more than 330 deaths happening in Peru. Brazil is another country where the dengue is a big problem. This graph is just to show how increased the number, the cases over the years compared with different regions, but in taking into account the number of cases, all the regions increase the numbers. So this Northwest North, so the most of them increase the number of cases. And we have a special consideration when we talk about the dengue fever and how the epidemic is changing, because at the beginning we have some areas or city where the cases are reported, but when the spread the Aedes aegypti, more small community in the same region, at the beginning just the main city, the urban city. After rural area and a small community were affected. And this behavior of the epidemic is the same in Peru and other countries. In the same region where the epidemic is running are affected, more small community, more rural area, and then increase the number of cases with new people who are infected. This graph is to show the number of deaths. The mortality is shown here, and the same trend to increase not just the number of cases, it's increased also the number of people who died for dengue fever. If you remember, WHO tried to reduce at zero the number of people who die for dengue fever. In addition, some estimation was made for calculate how much cost the dengue patient, dengue outbreak. For example, the estimated cost for dengue, including ambulatory hospital and federal cases, change from $516 to $1,688 to 2013. It's a lot of money. When compared, hospitalized cases had higher total cost for cases compared with ambulatory, with a big difference when compared hospitalized with ambulatory patient. Dengue cost is about to 1.1 billion a year in the Americas. This estimation didn't include vector control, who is very, very expensive. A few words about dengue and COVID-19. Many developing countries have or were affected by COVID-19, and they had overwhelming demand of patients, and the infrastructure was very small for the number of patients, and they had economic struggles, and the capacity for diagnosis was not was enough. But the problem is not just the number or the big number of patients with COVID-19. The problem we should take into account is to face the co-infection or two outbreaks at the same time. It means to have a COVID-19 outbreak and dengue fever outbreak. When you estimate the number of cases that can go to the hospital during a dengue fever outbreak, they can be 1,000. It depends on what kind of serotype of dengue virus are circulated at that moment. For example, in the last year, in the north of Peru, the hospital was collapsed by the number of patients that need to be receive treatment for dengue fever. If you put together two epidemics, COVID-19 and dengue fever, it was terrible. Fortunately, in Iquitos, for example, where I work, when the number of cases was go down, started the COVID-19 epidemic, and we was able to face just one epidemic, in that case, COVID-19. We have problems with diagnosis of infection because at the beginning, COVID-19 and dengue fever could look similar, the same symptoms. Over the days, you can find different regarding to the clinical chart or the clinical presentation, but at the beginning, could be similar, both disease. Lockdown have the potential impact over transmission And the information said the number of dengue cases was go down during the lockdown or epidemic of COVID-19. But after that, increased the number of cases. The information said some places registered moderate transmission and other low transmission, but after that, increase the number of cases. This is a study published in Peru. You can see here the week of the year, and at the beginning when it start the COVID-19 epidemic, the number of cases, this is in red 2019, in green 2020. At the beginning, reduce the number of cases. After lockdown, increase the number of cases. And this kind of behavior of the dengue cases was similar in different reports and different countries. What about dengue prevention? Vector control may be the most difficult area for reduce the number of cases. Many different strategies, major efforts has been made for the countries. They spent a lot of money trying to vector control, but it's not possible. Every day, the Aedes aegypti is in different place. This can find in different areas. For example, Lima is the main city in Peru, and we have autochthonous cases of dengue in Lima. In addition, the last outbreak in 2023 have a very big impact over the hospital because they have exclusive areas, exclusive room for give attention patients with dengue. It was terrible because the first time they see many patients with dengue fever, with complicate dengue infection. Other factor that could be influence over the spread, the vector, is the changing of the environmental, the temperature is estimated increase about 0.5 degree, the increase over the every 5 years, and this have impact over the capacity to spread the Aedes aegypti. This means for the vector control make very difficult. We have been working trying to vector control for years, for decades, and it's impossible. Every day find Aedes aegypti in different places. The egg have a special resistance to the temperature, to the adverse condition, and they keep sleep and until they have enough humid and temperature and a new vector ground from the egg. This picture showed the areas adequate to Aedes aegypti, who is the vector for dengue fever. And we can see here almost all the South America, many places. The most of the cases are concentrated in America. In Africa, we don't have outbreaks similar to South America. We have biggest outbreak here. When we check for the country level, the place adequate for Aedes aegypti, Brazil, Colombia, also Peru are adequate to grow this vector. No measure available to reduce the number because many factors have influence over the growth this vector, economic, cultural, and habit. Different factors have influence to keep the vector in and very high level, very high infection in the community. We have other important thing is inadequate outbreak detection and responses. Even the different city have experienced facing with a outbreak dengue fever. They every time they appears in a new outbreak, look like it's the first time they have to face a big number of cases. It's terrible because I has been training hundreds of physicians, nurses, and how to give treatment and give support to patients with dengue. But when I come back at the same place, I found the people didn't remember anything. Look like I said, who is the first time they are receive information about how to treat dengue fever. And the outbreak governance week because lack of clarity of stakeholder role, because they didn't consider, for example, last year that the epidemic could have many patients. But when they have the emergency room full of patients, they didn't know what happening, and it was late to implement the response because several deaths have happened. And this is the problem. We all, and this is the same in the different countries, the light teaming of responses due to poor surveillance. The surveillance system in the countries is weak to detect early when the number of cases increase. Even they detect the increasing number of cases, the responses implement to control the epidemic is bad because they don't have training physician, they don't have enough room, they don't have source funds to purchase different supply for give treatment to the patient. The same repeat several times, and this is a big problem in different countries, including Peru. For other hand, we training the physician about how to give treatment patients with dengue following the guideline of WHO or the guideline of Ministry of Health in Peru. But they make a decision, don't follow the guideline. They give inadequate treatment. They give treatment for the pain, for example, when the patient go to the emergency room when the abdominal pain, this is a warning sign, they give treatment for the pain. They back the home, go worse and dead. The only tool we have to face or try to control the dengue epidemic is the dengue vaccine. Currently, we have 3 products. The first one is Dengvaxia, developed by Sanofi. This was approved with FDA. The other one is Takeda vaccine. The last one is TB003, is called also Butantan vaccine because was implemented in Brazil by the Butantan Institute. This table showed summary about the 3 dengue vaccine. The first one, I said it was licensed by FDA here. 3 doses over 12 months, 0, 6, 12. The age is from 9 years old to 45 years old. The problem here is you can't apply the vaccine children under 9 years old. This is a problem because usually the schedule for vaccine in children should be at the beginning of the life, because when they try the vaccine with this population under of the 9 years old, they have more complication and more children was hospitalized if they have received the vaccine. And Takeda vaccine, only 2 doses, 0 to 3 months, and the phase 3 showed the range for age 4 to 16, but this vaccine have good efficacy. And the last one, phase 3 studies are available, single doses, very good if we try to make an intervention in terms of public health. We just have information about the study phase 2. About Sanofi or the Imvaxia vaccine, these have trials conducted between 9 to 16 years old. They registered an efficacy of 82%. The efficacy 82, and the efficacy for hospitalization was 79%, and for severe disease 84%. Very high percent regarding to hospitalization, severe disease, and confirmed disease. About Takeda at 18 months, the efficacy was found 80%, but go down to 62% by 3 years follow-up. They have different efficacy for each serotypes. And for example, for dengue virus 2, the efficacy was 95%. This is an important point because the most several charts could appear when the people are infected with serotype 2 virus. And have, for example, almost 50% for serotype 3, similar percentage for serotype 4. The problem is reduce the efficacy over the time according to with the clinical trials. Butantan, this vaccine is in phase 3 study, is running right now, including 16,000 volunteers across Brazil. Just in Brazil was implemented this study. They found 79.6% efficacy, but it's a partial result because only 2 years follow-up. But it was different efficacy when compared. Participant seropositive was 89.2% compared with 73.5% and seronegative participant. This table summarizes the 3 dengue vaccine. Overall efficacy and Imvaxia was 65.6%, Takeda 62%, in the follow-up at 3 years, and Butantan almost 80%. Look nice, but we need more information. There are different when we compare subject seropositive with seronegative for previous infection. The efficacy is higher when the patient had previous infection. For example, the Imvaxia have 81.9%, Takeda 65%, and Butantan almost 90%. they have very, very high percentage of efficacy. And seronegative is lower in the three vaccine. Then we have just one vaccine with FDA approved. The second one applied to FDA but removed the application. But Takeda was approved with EMA, but don't have FDA approbation right now. And Butantan don't have enough information about two serotypes. Given this trial was implemented just in Brazil, we have information only for dengue virus serotype 1 and 2, but we don't have information about serotype 3 and 4. And this is a problem right now. And in terms of public health, it's not possible go forward to use this kind of vaccine. And it's necessary to meet more cases to have enough information to use in different population. This Butantan vaccine was well tolerated. The second dose result in minimal additional boosting, then mean it's not necessary 2 doses, just 1 doses. And serotypes 1, when the people is seropositive, the immunity is higher, 100%, 100% seropositive. When the people have infection with a flavivirus before. One additional topic is what are the challenges in treatment in case of this complicated disease. The treatment for dengue fever, we can say we don't have a specific treatment. We don't have an antivirus. We don't have no specific treatment. We use only water. Crystalloids is the main tool to give treatment the patient with dengue fever, in special the patient who have plasma leakage and they reduce the volume and need to receive crystalloids. But if we don't have a specific treatment, we don't have a clinic tool to identify patients who can complicate. In this case, we need to know exactly the different phase, the different way to the disease go over the days. At the beginning, we have the phase and fever phase. The second phase is a critical phase, and the last one is the convalescent phase. Then we have 3 phases in the clinical charts, in the clinical manifestation of dengue fever. In this point, the warning signs is very important because when the people is going to the fever phase to a critical phase, appears the warning signs. In that moment, the physician can identify who patient could complicate and develop severe disease or complicate cases of dengue. This is vomiting, abdominal pain, the most important warning signs among other 7 signs. This is a clinical tool just for identify very early who patient could complicate and go bad and could death have result of the dengue fever. The last message, dengue fever, according to the information and the different different register is expected to increase in both disease burden and geographic range. Unfortunately, exists permanent risk for large outbreak in endemic areas. In Peru, right now, the number of cases have been go down, but we expect to increase the number of cases at the end of November, of December, or January. We don't have effective prevention and control measure, and this point have not changed. We don't have resource or infrastructure for surveillance and control. In different areas, the people don't have good clinical care in that endemic areas. New vaccines are the best option to face the control this threat, but in Peru, for example, we don't have available any vaccine right now. It's in implement phase. Takeda vaccine, 2 areas will be used as pilot area. One in the north of Peru, in the coast north, and other in the jungle, in Iquitos. And the Minister of Health expect to implement the dengue vaccine by 2024. But the best option to dengue control is to have a combination and different factor that include dengue vaccine, vector control, planning housing, different factor that unfortunately the country don't have right now, and we don't expect to reduce the number of cases. We don't expect don't have other outbreak and additional death, unfortunately. Thank you.
Thank you, Dr. Casapia, for sharing really the widespread public health problem of dengue, especially in Latin America. We have a few minutes to answer questions or hear perspectives. Dr. Miller?
Yeah, thanks so much, Dr. Casapia. We have a lot of medical students in the room, and in addition to, and thank you for sharing all this info on the epidemiology, but can you give us just a couple of lines on the, and you mentioned the overlap with COVID-19 presentations, but the classic bleeding from the gums, bone breaking pain, just so we have some clinical associations as well.
Yeah.
Thank you.
At the beginning, in the first 1, 2, 3, 4 days are similar, dengue fever and COVID-19. Usually after day 4 or 5, in case of dengue fever, reduce the fever and the symptoms are go down. In that part appears a warning signs. When the case is complicated, if the case is, it could be much better, the symptom disappears. In case of COVID-19, at the beginning, the day 1, 2, or 3, just fever and other symptoms similar to dengue, but appears cough, some respiratory symptoms. And the most severe case appears in COVID-19 around 8 or day 8 or 9, when immunity response cause damage of the lung. In that case, just are similar at the beginning, 2 or 3 days. After, respiratory symptoms are most important in COVID-19, but at the beginning could be similar.
Yes, go ahead.
Hi, thank you so much for speaking to us. I had a question about the cases report that were reported from like the data that we saw of how many cases there were. Were they all like PCR confirmed cases? And then a question that I had was, I believe that dengue in general is 3 and 4 asymptomatic. So I don't know if that's also the case in Peru, but were the cases that were reported there like symptomatic and were they like diagnosed or confirmed cases from clinic and healthcare facility base, or were you especially for the cases from like remote areas, or were you doing active surveillance to catch even the asymptomatic?
Usually, the cases reported in the statistic in this table was suspected cases because they have probably cases. But the surveillance system in Peru, for example, in Ministry of Health, have sentinel surveillance. They have some facilities or some hospital or health center where they take sample from the patient when fever, and they follow up a specific serotype and other cause of fever, including, for example, malaria and other, but they identify dengue virus, and after that they can identify what serotype is. Uh, but it's no active surveillance, just passive surveillance in a specific site, a specific clinic, a specific hospital, in order to know what dengue virus are spread, are circulating in that area.
Can you hear me? Oh, great. Thank you so much for sharing. So clinically, I'd just love to hear from you as well a little bit more. So I'm someone who's had dengue before. Do you also see that the patients more at risk for severe dengue have had dengue in the infection in the past?
Yeah,
And could
this
you
is
speak to the
I didn't talk about the physiopathology, but based on different countries and in different reports, the people who have a previous infection have more risk to have a severe dengue. If you have the first time, it's more probably you have just a mild symptoms, autolimited clinical chart, just a mild symptom or no symptoms. But in the second infection could be more severe. It's estimated about between 3 or 5% of the total infection could be go worse, could be complicated in the second infection.
Okay, any last comments? We're right at the hour. Dr. Casapia will be here for a few minutes afterwards if you want to come and ask questions, but let's please give our round of applause for wonderful talk, and it's really a unique moment where we get to have Dr. Casapia here from Iquitos with us. So thank you so much for taking the time to share, and thank you everyone for attending.